Family planning, we have found out from research, is not being well funded in Nigeria at the moment. There are a lot of bottlenecks, there are a lot of challenges that we're facing, and we're not there yet. For example, would you know that since 2013, the family planning budget is less than 1%, in fact, is less than 0.5% of the health budget in Nigeria since 2013 that we've been tracking the budget. And so we're trying to advocate for an increase in the health budget, but also an increase in family planning budget. PACFA stands for Partnership for Advocacy in Child and Family Health in Nigeria. It's a coalition of indigenous CSOs, of 6 indigenous CSOs that work in child and family health in Nigeria. We have specific areas that we carry out health advocacy for, but generally we also carry advocacy for an increase in health funding for all health in Nigeria.
Okay, so what's the role you are playing at this conference?
Okay, at this conference, we're supporting one of our partners, AAFP, who works in family planning at the national level. And they do quite a lot of work in health advocacy, in budget tracking, in health advocacy for budgets, for health, general health, as well as family planning.
And you are talking about infant death as a result of pregnancy. And there are measures to be taken to prevent that. Of course, you can't prevent death, but you can prevent things that can lead to that. So you can prevent accidents, especially those that are happening out of negligence. So you can neglect your wife when she is pregnant by not permitting her to go for ANC, antenatal care, and by not giving her those things that she needs. You can be mindful of what you need to do. So if you do that, you are saving lives. Some days back, on daily basis, we lost 110 women at childbirth. So you see the level of maternal death that we incur in this country. That means for you to come and attend a meeting like this, which will promote family planning in order to give women space so that they will be healthier, much more healthier, and to avoid that death is like saving life. And to neglect them is that killing people. So to save life in Islam, when you save one life in Islam, according to chapter 5 verse 32, is as if you save the whole world.
What I really cherish most is that the message has reached us. In Igbo language, they say that the message you give to the cloud has reached heavens. So we are going to take the message from here to our communities, to the grassroots, the children, the women, our daughters and wives on the best way to plan a family, the best way for self-reproductive system, and the best way to improve on the welfare of the family, especially in the area of maternal health.
The history of family planning methods is not new in Nigeria, like we all know. The challenges we have is the acceptability and how the intensity of its usage. And but with the advent of the development partners like USAID, shops, they have tried as much as possible to strengthen the capacity and provide quality services and integrate it with the private sector so that we can have a more broader acceptability among the population in the country, with the purpose of planning the family, with the purpose of controlling the population, and the purpose of spreading the acceptability, especially on such challenges like the religious constraints, the financial impediments, and all that. And I think the development partners have been doing a lot of great job. When they came about 5 years to Lagos, what they did was to do a mapping of facilities, especially in the private sector, and they actually mapped over 1,700 facilities that will be able, and they started training of hospitals and clinics, and they also trained pharmaceutical service providers. They have actually done a training of over 1,400 in the last 5 years, and that is enormous. And we see it as a challenge to our own services here, that the government should partner with the private sector to do some form of scale up, because with the percentage we still have in coverage now is still very low compared to the expectation. We are targeting about 40% in another 2018-2020, and if we can do, because the international partners will never be here forever, and the fundings will also not be here forever. So the government should see this as an opportunity that we have already trained personnel to do some, and partner with them so that we can do some form of scaling up, so that this can serve as a form of population control, and also improve on the maternal mortality, the bad maternal mortality indices that we have in the country. And I believe that is the area that the government should form their policies on. You understand? The private sectors are there. It is agreed that the private sector covers up to 60% of the service provider in provision in Nigeria. It's not only in Lagos, but if you now neglect the 60, it means that the indices will continue to be bad. So there is a need for a lot of collaboration so that we can see how, but the major part of the role that we have learned from this is that we should look at a way of retraining our members, and we cannot do that because it's costs. Some cost has to be invested, and that's why the government should partner with the already trained personnel on ground to see how they can scale it up with a line of chain.
Okay. Lagos has the largest, let's say Nigeria is the largest city, maybe in Africa, and would you say family planning services is very effective in the state?
Yeah, as seen by the demographic representation during the different sections that we have in the inside, it's well accepted in Lagos, and people are all out to use it. We have especially the long-acting, the family, the lack commodities. They are very, very accepted, and it's very good for people. And a lot of concerns has been raised, especially when it comes to religious organizations. But the religious organizations are even buying more in it now in Lagos than any other setting.
So what strategy did you apply to achieve that success?
Yeah, like I said, the partners came, mapped out, and we do a lot of outreach. We do a lot of canvassing market women. We did a lot of different programs to get a lot of people involved. The CDAs are also involved, and we're getting the result for it. But it can be better.
Okay. The target is 36% by 2018. Do you think it's achievable?
Yeah, it's really very much achievable, especially when we put all our strengths behind it. The problem is that we need to get a buy-in through the government. The government too will tell you they have a lot of challenges because it's not already budgeted. And I think we will learn from this to ensure, especially at the National Health Council, that health should be much more important. Because the way the Constitution is fashioned, it doesn't show that health is important. It shows that when you put the health in a recurrent expenditure, it doesn't make it to be so important. If you put it in the main budget, you know that this is what you're budgeting for health. You understand? And a lot of things can change. And it's also going to help the government, especially with this development of health insurance. I mean, we have a lot of challenges with health insurance, and if this can be factors into the health insurance, then we have a better coverage, because one of the militating factors is finances. But once it is imputed into the national health insurance and in the primary providers, then this we can achieve even better than 35%, 36% that we are aiming at. And one of those things that is meditating, especially when it comes to health insurance, is the fact that the middleman that we have enshrined, we should first of all remove it. And who are the middlemen? The HMOs. There is no need for HMO in the primary services. There is no need for HMO. the HMO should be removed. You understand? Let there be a direct payment to the providers, and you will see how liberated this thing will go. And we see a lot of change in indices. For the secondary provider, yes, you can pull the fund through the HMOs, but for the primary providers, let the payment be made directly to the primary providers, and that is going to, in effect, it's not going to change family planning alone. It's going to increase, and it's going to make better other health indices that we're having in the country.
Part of the mandate for Federal University Dutse, it has just opened a gender studies center, and we believe that Jigawa is part of the states that have some of the worst health indices, particularly on maternal and child health. And the reason why we are here is to see how we can be able to build more partnership, to be able to get a large hub of young girls and women from Federal University Dutse and also polytechnics that are in Jigawa, to see that how we can be able to make our women and girls more aware of all these health indices and how they can be able to sensitize and take care of themselves and also their reproduction.
Okay. Has there been any advocacy or sensitization on the issue of family planning? Or how deep is it in your state?
Well, according to different sectorial institutions, for example, for information, we have the radio station, where is one of the most easiest medium in the state where people get more information, and we have been able to liaise with Ministry of Health and also Education to have existing radio programs both in Hausa, Fulani and Kanuri languages, so that it can be able to expand the scope of information and outreach for people, to be able to now see how they can be able to even get awareness, and also how they can be able to reach out and access these packages of family planning services at the health facilities.
Okay, I'm sure you have been attending this conference from Monday.
Yes.
So what can you tell me that you've learned from all what you've been, from all the presentations you've made?
Actually, I'm quite excited, and I have to give my thumbs up and gratitude to PACFA. Particularly, this is a large hub where you can engage interactively, and it's also highly participatory, because we have been able to engage with a lot of stakeholders, both development partners, those that are outside the country, those are within the country, even those that are even within your state that you are not even aware of. And it has also bridged the gap for us to be able to know that even there are challenges, there are ways to tackle challenges. For example, there is the organization that is called the Challenge Initiative, how they have been able to showcase to us that even though there are challenges, there are ways to outcome those challenges by building more partnerships and seeing how we can be able to approach it in a multi-dimensional approach and also multi-sectoral approach to help to see that we can be able to pool more funds and be able to see how those funds can be adequately and appropriately used for the benefit of our women and also the nation at large.
So how are you going to apply what you've learned to your state? Family service.
It's true. The stands that have been established by some of these partners, we have been able to go around them, interact with them, get their website pages, get their contacts, and also get some of those flyers and posters and leaflets, not for anything but to also equip the gender center that is at the Federal University Dutse, because as I said earlier on, we have large hub of young girls now coming to get more education, and particularly in this training, it has been clearly stated that the only way to reduce the maternal and child mortality is by educating our young girls. And I think this is a vital tool, because even in Islam, it has stressed that you can go from here to China to get education, which is not a barrier. And I really was happy to see that it has come out clearly that the findings from this conference have really stressed out that education is the key to our success in reducing our maternal and child death.
Okay, what's to parents, couples, especially in the north, in the rural areas, concerning family planning?
Actually, for example, one of the legislature, the chairman health committee on health from the National Assembly, that's at the House of Rep. I was I was really tripped because of what he said. He now said that due to their own findings, because they have constant touch base with the Federal Ministry of Health, they've been able to see that actually the problem is not at the secondary or tertiary health facilities, but the problem is at the primary health facilities, and they will see how they can be able to touch base with different partners as well as other stakeholders to see how they can be able to leverage more resources at the primary, because at the primary health facilities, that's where the problems are, because they are more closer to the people at the grassroots. And we believe that if more resources, both human and financial, are being drawn at the federal level, are being drawn at the primary health facilities, I think more issues will be reduced at stake, because that is where the issues are. And we don't need to look at referrals anymore, looking at huge referrals. It will be reduced because all those services that we are seeing that they have touch base with secondary or tertiary, if they can be able to be tackled at the primary health facilities, I think that will be a great idea. And I think this is one of the key things that have come out from the conference. If legislators would have been acting like the legislator that just talked about this, I believe we would have been a great nation by now, and that would bring a transformational change that we all desire.
We have different channels of intervention. We have the social marketing, we have the social franchise, we have the outreach team, which this team that is here is part of the outreach team. And then we have our clinic, the one at Karo, and we also have where we support young people to provide family planning services in communities. We call them the MS Ladies. This is another channel of intervention. What we do basically for the outreach team is go to communities, sensitize the communities on need to take up these services that we render, and then have them come and take up. As it is here right now, we talk to our clients and then they ask the benefits of our services, the disadvantages and advantages. We counsel them through each of these processes and then have them take up a method.
So what particular people?
We provide our services for men and women. Yes.
And couples also?
You can be married. For both married and unmarried people, we provide our services to them.
In the issue of cervical cancer, what advice do you, what are the services that you give?
And we do the cervical cancer screening. We do the screening. Once you test positive to it, we provide the treatment as well.
So do you do it free?
Yes, our services are completely free for our outreach team. It's completely free.
So what are other diseases or other issues?
We do for the tent here today that we mounted, we also provide family planning services, which are free. They include both short-term and long-term method. We have the condom, both male and female, for young people. We have the tablets, the pills. We have the injectables, where we have for 2 months and 3 months. Those are the short-term method. And then we have the long-term method, which is the implant for the arm, under the arm, and then the IUD, which is inserted vaginally.
So how do you determine what particular method you give to?
It depends on the client, and we have an eligibility wheel, where if you have some health conditions, we take the wheel round, and if you are eligible, we'll let you know. If you're not, we give you options of other method that you could be eligible to, and then we have you take up any method of your choice.
Okay, in a case whereby a woman walks in here, say she's pregnant, and she doesn't want the baby, is there anything you can do? Do you provide such services?
No, we counsel her and then ask her to wait until the end of the pregnancy. She can prevent such occurrences from happening in the future.
In the future?
Yes.
So you don't prescribe any...
We don't provide any other services aside
maybe,
that.
What if maybe she misses her period 1 month can you do?
It's the same procedure. When we test and confirm you're pregnant, we can't offer you any of those services. It's one of the criteria we must check out for. We have to do a PT test for you. Once we confirm you're pregnant, we cancel you and then give you a call card for reference purposes, and then until you give birth. Once you give birth, we can track you to come back and take up a family planning method to avert that challenge from happening in the nearest future.
Your services stops as in before the pregnancy occurs.
Yes.
Okay, you don't do.
After it occurs, no, we don't have any control over that
Okay.
until you've put to bed.
Okay. This is your message. Where other places do you take this your message to? Do you take them to schools, communities, and rural areas?
Yeah, we do a lot of sensitization and community mobilizations. Once we go to a community, we start the entrance points from, it could start from the State Ministry of Health, as the case may be, down to the local government, down to the community. So when we are at the communities, we try to pass this message to the community heads too, and then have them, sometimes they gather their youth, they gather their men folks or their women group, and then we talk to them too directly before uptake.
How many states have they covered so far?
Marie Stopes covers, I think, almost 20 states where we are present, like work there every day, and we also do outreaches. So I can confidently say we cover the 36 states.
Okay.
Yeah.
Now the focus is especially the northeast.
No, we cover every zone.
No, I know.
Okay.
But the northeast, we have that challenge of family planning.
We
In the north generally.
we have our team stationed in Gombe that provides those services for those in Adamawa, Taraba, all those areas where there are no crises for now. They are there and they are providing those services there.
Okay. Do you provide service for IDP camps?
Yes, we do a lot of outreach activities in IDP camp. Yes.
So I'm sure maybe all the camps in Nigeria,
Yes, most of the camps.
most of the camps.
Yes.
Okay, you also give them all these materials.
Which of the materials now? Yeah, we counsel them, give them, provide them with a pamphlet. We could have some in different languages for the people.
I think there were 3 presentations. One on the use of mobile phone, interactive phone, to where people can talk to themselves. For the interactive nature of the phone, you get messages and education on family planning. Then there was a session that looks at a qualitative study that look at the barriers to access to family planning. Then the third one was on the uptake of services in northern Nigeria. A study was done looking at how women who took services, and when they asked them in the presence of their husband, they say no, they didn't take, which I think is trying to bring out the fact that people are taking, but when it comes to interviews, they are not opening up. I think both 3 of them were quite provocative. For the third one, looking at the concern that women take services, but they don't want their spouses to know, and so there's a possibility of underreporting of contraceptive usage in Nigeria. It's something that is key, and for me, it's something that all of us agree that we might need to think of innovative ways to do our research such a way that such passive group of people, we can also capture data coming from them. On the barriers, there was this extensive discussion on the side effects, and that we shouldn't take that for granted. The thing about family planning is satisfied users are likely going to make people to use more than convince people to use. If you use it and you're happy, you're likely going to tell your friend. But if you use it and there are side effects, then of course you will tell your friends also, and your friends are not likely going to use it. So the conclusion there is communication materials should attempt to address some of the barriers, especially the one of side effects, but you won't take that for granted. And I think that's a very strong message for everybody. There's really no easy answer, but we have to think of creative ways again to do that. The use of the mobile phone, for me, is also a very good strategy. But beyond that, we also have to factor in the fact that there are a lot of rural young people who don't have access to these smartphones. They're thinking of alternative ways of reaching these rural poor people and young people. I think it's something that we all need to think of collectively.
Okay. Talking about the side effects, what are the side effects?
There are several, but it depends on the method. There are some that if you take, it might make you to bleed for a while. There are some that may affect your menstrual cycle. So varies, but the important thing we'll tell everybody is before you use any particular method, first of all, discuss with the provider, because not every family planning method is suitable for every individual. The provider will look at you, take your history, and based on the history and your sexuality pattern, whatever, they guide you to make a choice, recognizing your physique, recognize your body and other things. If you take a family planning method on your own, or a friend asks you to do it, then definitely you have side effects that you might not be able to explain. But if you go to the right provider and the provider educates you and provide you with the guide, if there are side effects, you have someone to fall back on who can provide you the right, clarify issues that can remove the doubts and address your concerns as a user. So for me, the important thing is methods should not be initiated by itself, but meet a provider to guide you.
So is there a way you can, like maybe someone has a side effect in something and it occurs, what is there a way you can maybe help to like bring the situation back, maybe like the bleeding and all that?
So guys, go back to my first message that if you have side effects, go back to the source who provided it. And please, nobody should initiate a family planning method on himself or at the recommendation of a friend. Go to a family planning provider. The fact that your friend is taking pills does not mean that pills are good for you. The fact that your friend is taking an injectable does not mean it is good for you. Go to a provider. And if for any reason you are given a method by a provider and it's giving you excessive bleeding, they also know what to do to address that. In some cases, they might just stop altogether that particular method and switch you over to something more that is suitable to you. So you must not self-prescribe a method. And please, when you have difficulty, go back to your provider.
With USAID fund, SHOPS has been able to build capacity of 1,149 private providers that covers medical doctors, nurses and midwives, all operating in the private sector. Before SHOPS, private providers were providing FP services, but they were short-term methods. But SHOPS Advent had helped build their capacity to provide LAC, and so there is method mix in those private facilities today, meaning that if a client decides to go to the private sector in those 6 states, they will be able to access their choice, thereby reducing missed opportunity. Thereby, if someone does not go to the public, she may go to the private. Each way the client goes, the client access services, which is very, very key. Beyond service provision that is being institutionalized in those private facilities, we're also looking after the issue of quality. The private providers trained and mentored to improve on quality of service, which is not limited to family planning alone. Today, our private providers are also integrating FP into several service provisions that they provide to their immediate environment, meaning that anyone that goes to those facilities to access health services will hear about family planning, which was not the case about 5 years ago. Today now, family planning talk is proactive in the private facility. And going down the lane in this country, we've all been hearing it, not only in this conference, that the private sector needs to have a voice resonating through each level of service provision in the country so that we'll be able to meet the target we've set for ourselves. Not only that, we'll be able to sustain our gains. All hands on deck will help Nigeria to achieve its set target.
We found out that the issue of health in the urban areas is fairly, is fair. But in the rural areas, that's where we have the main issues, especially the issue of family planning. Most people in the urban areas, they're educated about the issue. But the challenge is the rural areas. How has your organization or as a private sector, how have you been able to penetrate, or what's your plan to actually penetrate the rural areas?
I would say in those 6 states where we've been working in the past 5 years, we don't stay in the urban alone. Let me say, for example, in those states, you won't find us only in Benin. We will When we enter a state, we'll map out the state to know how many private facilities would we have in the state, where are they located, and you know they are distributed according to their cadre. So in each state we enter, we train both private providers in the urban and in the rural center. And we don't only train, we also encourage the trained private providers to mobilize their immediate environment, because they've been in that community for a while. Community has some level of trust in them. And so if they go out to talk to the community, look, we are able to provide these services to you, it will do A and B for you, they are better positioned to attract and retain clients, which is happening in all those 6 states. So I would say our work in the private sector is not limited to the urban, but it's also going into the rural. Yesterday, in the session where private sector discussed their work in the past 5 years and their plans for future, you will hear one of them says, in the past in Edo State, if you want to assess long-term method, you would only get that in the general hospital or in the teaching hospital, but it's not the case again. Both the private facilities in Edo and inside Edo State can now provide it, meaning availability is no more a problem, accessibility is no more a problem. Client can access, the services are available. And all the facilities we train are also linked to commodities, so they will not stock out.
Okay, we have a target of 36% by 2019. Do you think it's achievable?
Of course it is achievable. If we've been able to move from where we were to where we are now, we are in 2016. We still have like 2 years. With the kind of momentum that had been gathered, we need not only to sustain it, we need to surpass it. So if we have those 2 things in our mind, sustain and surpass, we can achieve it. We can even do more.
One major challenge that has been identified is the issue of funding. How are you going to tackle that issue?
Well, our own project, as you know, is in the private sector. Though we're funded by USAID, we also encourage our association partners to look at the issue of scalability, looking for investment from other areas to take this beyond the 6 states where we work. And so for that, you will discover that means the USAID investment is not only utilized in those 6 states, it's gathering ability to spread the lessons learned and scale up. So if you look at funding comes in real cash. Funding also comes in scales. So if they are able to use what they have to scale the program up, and they can mobilize domestic resources. Because these days everybody is beginning to talk about resource mobilization. The government alone cannot do it. And so the private sector is the next place to look at. And we're already in the private sector. Though the private sector will work with the private providers. But of course, they can also work with pharmaceutical companies, work with other big companies to latch on corporate social responsibility to garner resources to move it forward. It's doable.